Hello and welcome to Healthline 3. I'm Terry Simmons. Today we're talking with Dr. David Hamm with Red River Cardiovascular Surgeons, which is part of the Willis Knighton Health System. We're talking about robotic heart surgery. We'll be taking your calls throughout the show. And as a reminder, please make sure you're in a quiet room with your TV turned all the way down so we can be sure and hear your questions and you can hear Dr. Hamm's answers. The number to call is 318-219-4569. You'll see it at the bottom of your screen throughout the show. Thank you again for being here, Dr. Hamm.
Good to be here.
I'm really looking forward to it. On the break, we were talking about different surgeries. And, we hear about heart surgery as a general, but what are the specific types of heart surgery that's done? Is it all, because it's not just bypass, right?
No, it's not just bypass. It's, we do the, I grew up, my family had a plumbing company. I tell them I'm still a plumber because I lay pipe, which is bypass surgery. And I change or fix valves, which we do with the mitral and tricuspid and aortic. And we do more pipe work, is when you have aneurysms of the ascending aorta, take tumors out of the heart. There are a lot of different odd operations we do as well, fix holes in the heart. And the truth of the matter is, it's teamwork with our cardiologists. It's not just the heart surgeon or the cardiologist. In the old days with the cardiologists and everything. Well, the cardiologists do a lot of invasive work. They do a lot of work that they completely fix the problem. And so we really work as a team to fix problems.
Yeah, some people may not know there's a difference in a cardiologist and a heart surgeon, and it all works together so beautifully. And your team also, your robotic surgical team, there's a team in there with you that specializes in this robotic surgery. How has robotic surgery enhanced, and what are the benefits for you as well as the patient with robotic heart surgery?
Well, for me, toward the end of my career, I found something I found it very, very exciting. Now, I love doing heart surgery. I like doing all kinds of heart surgery, but this robotic addition I have found fascinating. The smaller holes, the ability to be less invasive and do the same thing. I think we're just beginning to see how this will help people.
Yeah. Definitely.
And you've seen it in all fields. I mean, you've seen it in neurology, you see it in general surgery. My partner who does lung surgery, Dr. Mull, who actually did my bypass surgery down the middle. I wish he would have had the robot at the time, but whatever the case, there's so many things they're doing well with the robot, and I think that it's going to only get better.
Yeah. And you said yourself you had a little bit of resistance to this at first. Why is that?
Well, it's because I'd lived through the heart port era, where we did make small incisions and without robotic tools, with just straight tools, took down the internal mammary artery, and we'd do bypass surgery through this small hole. Now, the truth of the matter is, to pull up on the ribs, and a lot of older people, we were breaking ribs and causing more chest pain than I thought we were with making an incision down the middle. And but incisions cause different pain for everybody. My bypass surgery, I didn't think the incision was that bad. You might talk to my wife. She may give you a different story. I'm not sure how good a patient I was. But there's definitely, if you go on YouTube and watch robotic surgery, you see these little holes. It's magnified times 10 rather than through my loops by 3. You're more precise in what you do. We hopefully cause less bleeding, and I think all of those things lead us toward a better outcome. So those are the hopes we have with robotic surgery.
Yeah, definitely. Definitely for you, being able to, like you said, you're at the other side of the room, but you can see better in there than you could with your loops standing there at the patient. You
can see incredibly better. It's like I told you. As we've been doing more and more, and I'll use it on just, even if I cut down the middle, I'll take a mammary down with the robot, and what you can see with the optics of the robot and how fine the movements are. It's different.
It's incredible.
Yeah.
And you've got a team standing there, and so you'll have them, like you'll tell them to put the scissors in my right hand, or they're changing the tools out for you.
You do. The process is like with general surgery, thoracic surgery, all the other guys, whatever they do it, you're sitting there over in the corner of the room looking in a screen. And with a microphone, such as I'm talking, and everybody hears. My assistant is very patient with me. April sits up there and she puts in the tools I ask her to put in, and it's a very, everything in surgery that's done well is a team.
Yes.
We've got great anesthesia. The ladies and gentlemen that are assisting in surgery, they're all, it's amazing. They're very dedicated to what we do in taking care of the patient. And I that's another thing that makes it so fun. The ICU people, very I was up a good bit of the night last night with a patient that was having some issues, and you know that you got this whole team of men and women that are there just to make that person get through it. And that's you know, it's just a very positive experience for me. I've enjoyed it.
And that's who you want, you know, to working on you. Someone who enjoys what they do, enjoy the people that they work with.
And you want somebody that's got a team like that, you know, just really. Yeah, I'm if you ask them, they may say he's kind of hard on us. I don't know, but because I do expect a lot.
Sure.
I expect them to be really good, and you know what? They are. They're really good.
Yeah, but and the communication has got to be huge. It's got to be direct. You've got to be able to say exactly what you need in the moment.
Yes.
Yeah.
They've learned to call me. All the young ones learn to call me. Yeah.
Well, it's really interesting how even with the robot, it still takes a team of humans to work together to create this life-saving. Yeah.
Without a doubt. And you know, the patient's the center of attention. That's what it's all about. And that's what it's not about somebody's career, or it's not about, you know, it's not about really the personalities there per se. It's the whole team wants that person to do well. Because it can get tough.
You can, I'm sure. That's
Can.
even though I know you, and I'd love to have someone doing this life-saving surgery who finds it thrilling and fun and exciting to do it. You want someone who really wants to be there. It's still got to be the forefront in your mind and your heart that there's a person's life. There's a person on the table there that it's in your hands.
That's always the important thing. And it's interesting when you do an operation, even if it's something, and you may be anxious, or it's big, or the patient's not doing well, and you're trying to get prepped and draped and cut, or you're pushing on their chest. There is anxiety with it sometimes, but it's so funny that once you make an incision, it all goes away. It just all gets smooth.
Yeah.
As far as anxiety, I mean, it's not always smooth, but as far as your emotional investment, you do stop and just do your work.
Okay. Frida Day, thank you for calling us. What's your question for Dr. Hamm?
Good afternoon. My question is, I had a heart cath about 11 years ago, and I have been diagnosed with Afib. Would any type of surgery repair Afib?
Well, that's a great question. I had atrial fibrillation after my bypass surgery, and I know how uncomfortable it is. If yours was like mine, it was just miserable. So I empathize with you. There are things that can be done in the cath lab in particular that are excellent for atrial fibrillation, and where they can put burn lines on your atrium to get you out of atrial fibrillation, especially if you hadn't had it for a long time. Now, the longer you have atrial fibrillation, the harder it is to correct the problem as your left atrium dilates. But there's several aspects to it. You want to be in a good rhythm, and then you don't want blood to collect in your left atrial appendage, which is a potential stroke. So there are things I would call operations, but they're done by cardiologists, where they would burn the left atrium to keep you in rhythm, and then they would put a device into your left atrial appendage to prevent you from having a stroke. So atrial fibrillation is a big deal, and you do well to get it tended to. Did that answer your question?
Yes, I'm 75 years old. You're
young.
Young.
Yeah.
But thank you, the only person that tells me that. But
I'm starting to tell myself that.
Is that something you would do for a person that was that age?
Would they do it for you?
At that age?
At that age, absolutely.
Okay.
Absolutely.
And are you a cardiologist?
No, ma'am, I'm a heart surgeon. The difference between a heart surgeon and a cardiologist, if you ask them, they'd say they're the smart ones and we're the mechanics. So
okay.
We do the work, they do the thinking. But actually, more and more, the cardiologists are the ones that will do all the work in the catheter for the AFib. Now, when we do surgeries and a person has atrial fibrillation, we will add on those burn lines directly, and we will take off the left atrial appendage. But that is usually accompanying, say, a mitral valve repair or coronary bypass or some other multiple procedures. But the cardiologists can do all of these burn lines in the cath lab, and they do a great job with it.
So you'd recommend to see a cardiologist then?
Yes.
Instead of a heart surgeon?
Yes, if that's where you start. And if the cardiologist thinks that you have other reasons that would need open heart surgery, then of course we would do those burn lines when we had the heart exposed. But if you don't need anything else and you simply have atrial fibrillation, find a good electrophysiologist, and we have several in town, and they will do a great job. Mm-hmm.
Okay, that answered my question. Thank you so much.
You're welcome.
And that's there's so many questions in there that we can talk about. Also, if someone's listening and they don't know what AFib is, let's describe that.
Well, atrial fibrillation is where the atrium is the upper chamber, and it primes the lower chamber, and they do it in sequence. So the SA node fires, it goes through the AV node, and those are just electrical modifiers there. And so it squeezes, it fills up the lower chamber, and it squeezes, and it goes out to your body or to your lungs. When you're in atrial fibrillation, your upper chambers are just wiggling. Oh. So they never really, all the loading of the ventricle is by passive flow. And a lot of time when you have an atrial fibrillation, your heart rate is irregular, and its output can be not equal every time. So you feel yourself bumping along, and all of a sudden, bang, a big one hits, and it's an uncomfortable feeling, especially when it's new. Now, a lot of people, as they have AFib for a long time, atrial fibrillation for a long time, they get used to it and they really don't notice it. I can tell you, when I went into atrial fibrillation after my heart surgery, I noticed every beat. It was uncomfortable.
Yeah, and do you want to talk about what they had to do to fix it for you?
Just give me medicine.
Medicine?
Yeah, medicine. Okay. Most people with atrial fibrillation can be treated with medicine.
Okay.
And that's what the electrophysiologist, who's very familiar with those medicines, will get people on the right medicine, but if they can't keep them out of atrial fibrillation, they go on to do ablation.
Right, right. And this is a condition that you would have, so people can say, I have AFib, I live with this, or... A
lot of people will live with AFib, and the important thing, if you live with AFib, you will have a blood thinner. Yeah. Because the worst thing to me in everything I do, or I think that people have, is to have a severe stroke. Yes. And they can't live the life they would like to live. And that's a very difficult thing. Yeah. Mm-hmm. So what technically exactly happens when you have a stroke? What does that mean? What's going on in the body when you have a stroke? What happens is that a clot, it can either be a bleed or a clot in atrial fibrillation will go from the heart out into the arteries of the brain and keep blood from going to a part of your body that maybe has speech or maybe has movement of one side or the other of your body. and so they can just kill segments of the body. Now, some people have strokes from a hypertensive bleed, and that's why keeping your blood pressure under control as we get older especially is so important.
Okay, those
So
are
it can
different.
be from a clot, or it can be from from bleeding from rupturing a blood vessel with hypertension.
Okay.
Mhm.
And so talk about again from our caller. There's a cardiologist and the surgeon. And when you're the surgeon, they come to you. That's referral from the cardiologist. They've gone and done everything. They said, okay, let's talk about surgery. We've done everything we can with medication, or maybe not. Maybe this is something you need to talk to a surgeon about. That's when they see you.
Exactly. They will refer. They'll do the heart cath. They'll do the electrophysiologic study. They'll do whatever. The echocardiogram shows valvular dysfunction or ventricular dysfunction, and then they will refer if there's a fixable problem, such as a blockage or a valve that leaks or a valve that's too tight. Then we get involved. One of the great things we do at Willis Knighton is we have a Cath Conference, we call it, where the cardiologists and surgeons meet together. And if we have a difficult problem, we get a bunch of opinions. Three of my partners, so there'll be 4 surgeons sitting there, and we'll have as many cardiologists as who will attend, and we have some come in by video conferencing, and we'll show heart caths, and we'll say, what do you think we ought to do? This is a tough case. He's got a high risk. Do you think that you guys can do better with a catheter, or should we go ahead and do this as a high risk operation? So the high risk conference, the Cath Conference, is another example of how cardiologists and surgeons work together to try to do the best thing at the lowest risk.
That's just another amazing advantage of being involved in this system. You have so many surgeons, specialists that will come together and look at a case, which is probably fascinating, and put input on something that's not even their case. How often do you have these
Once a
gatherings?
week.
Once a week?
Once a week, yes, we do. We as a surgical group, we have Cath Conference on Friday, and on Monday morning we have journal review, where we'll review the latest literature and try to keep up to date with what's going on and what's being written. Some you can believe, and some you shouldn't believe. That's after being in this for a long time and going to the meetings and listening to different people present. There's some things are true and some aren't.
And is there discussion about?
Yeah,
I don't think that's true.
And that's why I talk with people I know and I trust. And I mean, other than operating and working the nurses, finding colleagues to work with that have similar values.
Yes.
That really are putting the patient first. That's a thrill to find people like that, and we have cardiologists like that in our system, and that keeps you working. That's fun.
Yeah, and I think that's something that we might take for granted. Those of us who aren't doctors or surgeons are in that field. You just take for granted that's the priority of every doctor, every surgeon. And while it probably is a huge thread, there are different priorities and different reasons for getting into anything, even medicine, right?
There is.
Yeah.
Yeah. Some, you could go in, it's like everything.
Yeah.
There are good motivation, good reasons, and there are other reasons.
Right.
And but I feel like it's a great field, and that most everybody I know, at least everybody that's happy, is doing it because this is what they really like to do.
Good point.
There's some people who have gone sour, and it just didn't turn out, and I'm sure in your business as well,
Sure.
It didn't turn out like they thought it would be, and they don't like it as much. You don't want to be caught in that, do you?
Yeah. No. So I guess, compassion is just a big thread in anything that we do, whether it's...
There's always that. I mean, there's
Yeah.
always the human element where you love your neighbor as yourself, and there's no doubt about that. That's the motivating force behind your decision making.
Right.
And oftentimes, that's at the end of the day, that's when you sit there with somebody in your office and you say, well, I can tell you this is what I would do for me.
Yes.
And that's really the litmus test about whether or not you're going to operate on somebody. But I'll be honest with you, a lot of it, becoming a heart surgeon, it was fun. It's always been fun.
Yeah.
a lot. And I told my mother. She said, "Well, she wanted to know about the heart surgery." I told her because I couldn't sit in an office and talk to you all day. That's the reason I couldn't be an internist. I admire internists like crazy that they could sit and talk to my mother all day about what burned and what didn't, and all those kind of things. I wasn't made to do that.
No.
I'm a mechanic.
You're the mechanic.
I'm a mechanic.
You're the plumber. Yeah. And it just shows there's a place for everything. Medicine is so broad, and that's why there's specialties. That's why some do this, some do that. And internists, that may be why they're there, because they love to sit there and figure it out and talk to the patient. And you like to get in there and...
I like to fix it.
Yeah, fix it.
And that's not always worked well in a marriage, because I've learned over the years that sometimes you're supposed to listen and keep your mouth shut.
Oh, maybe that's what I did wrong too. Listen, keep your mouth shut.
I've learned when to listen. It took a while. It was painful.
It applies across the board, let me tell you. So speaking of relationships and partnership, do you get to choose your team that's in there with you? Do you work with the same people each time? How does that come together?
I've got people that have been with me since when I was trained at the Mayo Clinic, and we decided to leave because it was so cold. And we went to Illinois, and I stayed there 6 years, did a ton of work. And I don't know why I didn't look at the map. Illinois is cold.
It's cold.
So anyway, we ended up in Shreveport again. And I've worked with people for 25 years, some of them.
Well, we're glad you made it here.
Yeah, Patricia. Hello, Patricia.
Hello, Patricia.
Shout out Patricia.
Yeah.
She's put up with me for a long time.
Well, I'm sure it goes both ways.
Yeah.
Hi, James. Thanks for calling. Do you have a question for Dr. Hamm?
Yes, I do. I just fell and broke my leg. I believe it was on the 7th of July, and I'm still down over it. But I'm having dizzy spells, and my ears itches, and around my ears, in the back of my head, it feels like worms are crawling in it. And anyway,
anyway,
I want.
Are you having those are your main problems? Are you having chest pain or anything like that?
No chest pain. Just got this. My scalp itches on my head, around my ears. My ears itches, and it feels like little worms are moving in there all the time. Not all the time, but most of the time.
Well, that's enough to drive you crazy, isn't it?
Yeah, almost.
or drive you crazier. Well, here's what I think. Those little things that bother us consistently are terrible. Here's how
it usually hits me.
Yeah.
Let me tell you how it usually hits me. When I lay down in the bed.
Yeah.
Anyway, it feels like my bed's turning over to pour me out, or either I'm putting my feet up and my head's down.
Yeah.
And sometimes it feels like my head's spinning around and around on my neck.
Well, I think you've got a situation there, and I would go to your internist and tell him all of these things, because I can tell it really bothers you, and if you can't get a good night's sleep, what good are you anyway? Huh?
Well, not much.
Not much. That's
not much.
Broken leg and you can't sleep. I'd say you're in trouble, James.
Well, I meet up with old age too. I'm 90 years old.
90, goodness gracious. Well, you need to go to your doctor and tell him everything you've told me, and I bet you can fix it with something.
Let me tell you something.
What's that?
My doctor retired.
Oh no.
My doctor retired, and they turned his practice over to two some kind of nurses, and I forgot what they call them.
Nurse practitioner.
And anyway, I've been to both of them.
Yeah.
And I ain't going back to if I don't never go to the doctor anymore. It's gonna be cause they there. I ain't never going back to them.
Oh mercy.
Well, now they telling me that they got a doctor that signs the stuff, but they do. You go over and pay them $100 and something, and you talk to one of them women. And in my opinion of them, they ought to be somewhere washing dishes or something, sweeping floors or something like
Oh,
that.
okay, James. Now we're getting into something other than the broken legs and the heart surgery.
I tell you what, you need to take your itchy ears and your broken leg and go find somebody you like, and they could fix you up.
That's right.
Okay.
It's
Thank
good
you.
talking to you, James. You have a good day.
Thank you again for calling, James. And again,
Glad
we
my
wanna-
daughter wasn't here to talk to you, James. Your ears would have been itching for sure.
You gotta be careful. You gotta be careful nowadays. I want to remind everybody we're talking about heart surgery today and robotic surgery, particularly with Dr. Hamm. And and we have a Betty on the line. Hi, Betty. Do you have a question about heart surgery for Dr. Hamm?
Well, I have a question about poor circulation. My feet and legs, they stay dry, and I grease them, and they still stay dry. And around my ankles, it's got purple discoloration. Could that be from poor circulation?
Let me ask you this: can you walk?
Well, sometimes my legs is weak, and I have to walk with a cane.
Yeah. Well, I would say this. I would say that you need to go to your doctor, and he needs to feel for your pulses, because you don't know if you've got arterial disease or venous disease. And if you've got bad arteries, you're in a bad way, and it really makes it hard to walk. But if it's just from your bad veins, you can use support hose to fix a lot of that. So you go to your doctor and get him to feel the pulses in your feet, okay?
Okay. When I do go to a foot doctor.
Yeah?
Mhm.
Well, I think
So
you make sure
he
you
can tell if I have poor circulation.
Yes, he
on
can.
My,
Yes.
thighs.
Okay.
Okay.
Yes, he can.
Okay.
Okay.
Thank you.
Thank
You're
you.
welcome. Thank you so much for calling. And a good point with these questions too. Sometimes we don't really know when we talk about circulation. Is that also something to talk to a cardiologist once we get to the heart surgeon? Even do all of these go together?
Absolutely. I mean, I think that when people come to you, you need to listen.
Yeah.
Listen to them, and they will begin to tell you a story. And they may start off way off base, and eventually you figure out that their story has to do with a bad heart.
Yeah.
And that's why they were sent to you in the first place. Or a lot of people just have problems, and their symptoms. If you listen long enough, you'll hear what the real problem is. Yeah.
You're right. So you're right. It is all about listening. Yeah.
Yeah, if you want to.
If you want to. Well, it's just interesting. We'll get the calls, and when someone's talking like a specialty, definitely with heart surgery or anything vascular, and we might not really know if. So these callers, I love it when our viewers call in because they'll have something they think might be related,
Right.
and so it is good to hear. You don't know.
Well, and I'll give a shout out to the primary care doctors, nurse practitioners, physician's assistants, internists, emergency room doctors. I became a heart surgeon because that meant I could be very good at a very narrow field.
Right.
And now there's a ton to know, but I can tell you what, those people that see people that they have to know a little bit of everything, I don't think I would have done well with that. And I think it takes an exceptional physician or nurse that's willing to go out and listen to this broad list of things and try to come up with a good plan.
Yeah, it must be fascinating.
I
Yeah.
couldn't do it. They do a great job.
Yeah,
of
I don't
it.
think so either. They've got to be listening for the thread and the key words to kind of, and then it's just an educated guess unless they absolutely know. Let's try this.
They
Let's
work.
test.
They weed it all out,
Yeah.
and they'll come to the good thing.
I agree.
Yeah.
Well, Dr. Hamm, it has been such a pleasure talking to you today and meeting you. Thank you so much.
Well, it's been nice to be here, and I hope that we help somebody, to where they can go to their doctor and ask the right question.
I'm sure they did. It's been
Yeah.
very informative. Any one thing you'd like to leave our viewers with today?
Well, I just am grateful to be working, and I'm grateful being in a community and a hospital that
Okay.
does all this good stuff.
All right. Thank you so much. Thanks for joining us. We'll see you
you.
next time on Healthline 3.